thinking about what a veteran is, we tend to think about veterans who parade at the cenotaph, who are older, probably from the wars. Now it's probably not so much Second World War, but it's more about Korea, Falklands, wars that seem to a lot of our population historic. And we think about older veterans, but we don't think about the range of veterans that it actually is. Obviously, we still have a high proportion that are elderly because of national service, but that is changing as the people that served in national service sort of move on. We're going to have a shift towards a younger, on average, population. Obviously, that's quite topical today because they're talking about national service again, aren't they? And I was then suddenly thinking about what will that impact? How will that impact veterans? Straight away. But we need to really be thinking that this is quite a variety of people. People who are young, people that might have only served a very short period of time, and the actual definition states that it's anyone who served one day in the armed forces. So you don't have to have served any length of time in the armed forces to be classed as a veteran. You don't have to have done anything specific to be a veteran. Not every veteran has been deployed. Not every veteran has been in combat. Some veterans have done very similar jobs to the civilian world, but they're still in that military culture, and they have, they may have been exposed to things, even though they've done a very similar job to the civilian world. They may have been exposed to things in a different way. For example, I had a chef, and you would think, what trauma has a chef had? But he had been lost behind enemy lines as a chef on his own with a driver. And so, that then the context of that person's experience is very, very different, and we need to think about that. So we have quite a range of people, and we've got to think about all the forces. So it's Army, Navy, and Air Force. Also includes Merchant Navy if they've been operations. So for us, if we think about the Falklands, there was a lot of Merchant Navy support for the Navy. And they would have, they wouldn't have been that far away from the firing ranges as such. So they would have been classed as a veteran because they would have actually been almost deployed as support for our actual Navy. And it also then politically also included former Polish forces under British command, particularly in the Second World War, because they weren't treated fairly immediately after the war. So they have now, that was a political reason why we really need to emphasize that. So in 2016, we had an estimated of 2.5 million UK Armed Forces veterans. So if you think about that, that's a significant proportion of the population. And then you've got to think about the family around that veteran as well, who've been impacted by that veteran service, children, dependents who've moved around the country and things like that. And I talk very much in my larger teaching sessions about the impact on family as well, and the fact that we need to consider when we're thinking about veteran services, a lot of veteran services also include families in that because they have a different culture that they've been around and a different set of experiences as well. So we have some issues with the definition, because obviously one day in service is very different to being sort of 30 years in the army and retiring at 50 odd to somebody who's 19 and leaving the army after a day. You can see that there's issues with that, but we need to have quite a wide reach, because we have to think about the fact that you don't just turn up in the army and you're suddenly in the army. You've wanted to join up, or you've done some work before you came into the army to get into the army as well, and you've done training, whatever it is. So we have a whole range of veterans, and they can look very disparate, and they don't necessarily look like veterans when they walk into your practice. Some of them look very much like veterans, and some of them you would never have ever believed that they were a veteran. And we also need to remember that as time's moving on, we're getting more and more female veterans as well. And obviously we need to think about that in the impact of what their experience might have been in a very masculine, stoic environment, particularly thinking about things like drinking culture, physicality, things like that. And we also need to think about the LGBTQ population as well, because it was only in 2000 that it became legal to be gay in the military, or so it was before that it was illegal. And there are a lot of LGBTQ veterans who were treated very, very unfairly, very, very, you wouldn't imagine how they were treated. when they were arrested for being gay in the military in 1999, which is in a lot of our living memory, as you can imagine. I was actually working with the military around that time period when it changed, so it was quite massive impact, So we need to remember that these are our veterans. Our veterans have had these experiences. So we also need to think about how a veteran might identify themselves, because we talk about veterans, and now I've told you what a veteran is. You know what a veteran is, but a lot of people who are veterans don't identify as veterans. That might be for lots of reasons. I know veterans that won't identify. I've got a lot of veteran friends who have served in Northern Ireland, done some very difficult things, and if they think you're Catholic, they might not want to tell you about their service, so they might not tell you that they were a veteran, because they might think you might, they think, I might have, if you're Irish Catholic, for example, they think, well, I might have harmed one of your family. They don't, and they don't want you to think badly of them, and they think it might impact on that interaction. It's really important to think about that. If you're of an ethnicity as a doctor, they might not want to, to talk about it in case you are from one of the countries that they have been in and maybe done quite difficult things in, so because they don't know how you will think of them, so they might perceive that they might be treated differently, or they might not want to put you in that awkward situation either, so they might not want to identify themselves as a veteran for that and many other reasons. But also they might not think of themselves as a veteran. So we tend to say, have you ever served in the armed forces? It gets a better pickup of who has actually served and who hasn't. So the question is important, but also how you ask the question is important. And it's important to sort of think about as well how you record that question. So, and using the appropriate coding, and there's a whole lot of advice about that I can access for you should you need, but that's all on the Royal College of GPs training as well that you can access, but using the right coding for the right service. Unfortunately, what we find is, and I'm doing a lot of work with the ICBs looking at veterans accredited GP practices, but also veterans accredited trusts, and unfortunately that coding that you might code them at doesn't necessarily pull through to the acute hospitals and vice versa. So we're not matching that up. So how do we communicate that this person's care might need to be considered in the context of them being a veteran? Then also, we need to think about uptake. So this poster is available to all GP practices through the ICB, and you can get it off myself. So we need to think about how we get people, because it's all very well saying, well, we can code them, we can ask them and we can code them, but we actually can proactively ask them through advertising. So we actually sort of ask them to tell us. So we very much use the language. Thinking about the language is, they might not want to tell us because they don't know what's in it for them. They might not want to tell us because they think there might be something negative coming from it, or they might just not want to be put on a list if there's no value on it. So it's about making sure that they're feeling like they're helping us by telling us, so it's that help us to help you, is the real theme that we're looking at to get them to engage with GP accreditation and practices, and just telling GPs, for example, that they are veterans, because what's in it for them, what does it, it's not necessarily what's in it for them, but it's what is in it. If I tell you that I'm a veteran, will you help me and my colleagues, my peers? Because they're probably they tend to think more about the others than themselves. So it's like, if I tell you, will this actually help other people? The other thing is that with veterans, if you say you're a veterans accredited, veterans friendly practice, are you actually, what does that look like to the veteran? Because you can tick all the boxes on accreditation, yet not look like a veterans friendly practice to the veteran. So it's very important to have this sort of posters to say, we're trying to help you, can you help us help you? So there's a whole load of resources we can help you with in that sense. So thinking about where this has all come from, I mean, in 2000, though we had the Covenant, the Armed Forces Covenant, as we sort of know it now, what we're familiar with now, and that very much was talking about service in the armed forces being very different to experiences anywhere else, in the military, in other occupations. The experience in the military is very different to your experience in even medicine. we compare medicine quite often with the military, but it's not the same. We're not under military law, for example. We don't have to, we can't get arrested and put in jail for turning up at work drunk, just for, or even turning up as a patient under the influence of alcohol. We can't get arrested just for that. We can get arrested for what we do and the risks we pose, but we can't just get arrested for that. But they could. They can't, I know government is trying to make changes, but they can't strike, for example. They support, when we strike, they are the backup. They support us, but they don't have the right to strike. Those are sort of things that they don't have. They relinquish a lot of things that we take for granted by joining up to the military. So there's that, and then there's all these uncertainties. It's not just about going off to war and war kicking off and us and them having to go to war. Just posting. They're moved around the country a lot more. They can be moved. They can be confined to barracks immediately. My wedding, for example, was 11 days after September the 11th, in 2001. A lot of my guests couldn't come to the wedding because they were all confined to barracks just in case they were needed, because we didn't know what was going to happen. That's suddenly, at very, very short notice, they're asked to do things that we would have a lot more time to plan for. Generally, obviously, we've had lockdown, which was probably the nearest we've ever been to that experience, but that was very, very different. This is more common for them. And then we know there are dangers, and it's about 1 in 1,000 per year is the rate of death in the military, which is 150 times the general working population. And it's not just the number of deaths, it's thinking about not just the number of deaths that they have, but thinking about when for one death there's probably several injuries. For that death and those injuries, there's probably many people, quite often their peers, who are having to deal with the aftermath of that. And so there's a lot of people impacted by that one death, other than the one death as well. So because of this, we promise to support and help people in the armed forces when they need it most. And they should not be, they should not face any sort of disadvantage because of their service. So we need to bring them at least up to the same level of support that the average civilian would give them, would get. But we also need to think about what they've been through and how that might sort of impact on them, but also what we might owe them as well. So next slide, if you don't mind. So when we're thinking about the covenant, it's like I said, it's about serving no disadvantage. There should be no disadvantage to someone for being in the military, having been in the military. And continuity of public service is part of that. And if you think about it, I tend to think about this in the family's context. If you're in the military and you're moving around the military and you're a family member, and say, for example, the child of of a serving personnel has got suspected ADHD, so they're 7 and they're on the waiting list down in Aldershot, and they've got to near the top of the waiting list, and all of a sudden, they're posted up to Catterick, and that child has to move up to Catterick with, obviously with a family, and they used to be put on the bottom of the list for they used to have to potentially go back to the GP and get re-referred, even. To ADHD services in the local area. But now the covenant from 2000 onwards has said that child of that serving personnel needs to be put at the same point in the waiting list that they were in Aldershot, at the same point in, say, Northallerton at Catterick, so that they don't get put to the back of the queue just because they've moved, for example. So it's things like that continuity of public service is not just for the serving personnel, but for their families. And obviously with serving personnel, as well as veterans, you've got serving personnel and veterans, and serving personnel don't tend to need GP services unless they're sort of acute services, acutely needing them, because they're dealt with by the medical officer, but their families are dealt with by civilian services. So it's the families are moving around with the serving personnel that is really important for in the first instance. And then it's about continuity when they're transferred out of the military. And they deserve a proper return for what they've sacrificed. And remembrance, so Remembrance Sunday and all that, all that stuff at the cenotaph and everything else, that's all part of the covenant. And that sounds not very medical, but actually when we're thinking about the impact of trauma and the impact of moral injury, which is a component of trauma and a component of mental health disorders, actually that we know that remembrance and ritual, and those remembrance rituals are very important for healing. So it is, although it doesn't sound very medical, it is actually very, very important to their health and their mental well-being. So the key areas in 2000 for the NHS were transitioned into NHS care, prosthetic provision, because you've got younger people needing prostheses for a lot longer, who have probably got higher expectations of the prostheses as well, and implementation of mental health services for veterans and families. What was really frustrating was that the Covenant came in 2000 and mental health services took till 2012 to come into place, and it's only now that really Op Courage has really sort of developed a more effective. I've been part of all those mental health services, so I'm not slagging anybody off, but I have been through it, all the changes, and it's only now that we've really got a cohesive service that is trying to be similar nationally, but also managing the patients well, as effectively, as well as trying to engage them in appropriate generic services as well. And it used to be that this was all sort of like a code of conduct, but now it's a lot more of it is written into legislation. So so when we're looking at what NHS England says about managing this, they say veterans should receive priority treatment for a condition that relates to their service subject to clinical need. So this isn't prioritising all veterans with all conditions. This is saying NHS England is saying, because if they've got a condition related to their service and it's of similar clinical, and if they've got similar clinical need to a civilian who hasn't got a service attributable condition, that person of equal clinical need should be prioritised because their health condition relates to their service. So this could be PTSD, this could be injuries due to IEDs, but it also includes things like skin cancers if they've served in somewhere like Aden in the 60s, where they would have been shirt sleeve order, so they'd have had rolled up shirt sleeves and expected to have rolled up sleeves and not have sun cream and being exposed to the sun. So it's sometimes you have to think quite laterally for that. And it also, NHS England says, those injured in service should be cared for in a way that reflects the nation's moral obligation to them. And this is by healthcare professionals who have an understanding of armed forces culture. So this is why this sort of training comes out. And then the NHS long-term plan states to ensure all GPs in England are equipped to best serve our veterans and families. Over the next 5 years, they rolled out veterans accreditation. And that included, when we look at veterans accreditation, it lasts 3 years. It means that it can better identify and treat the armed forces. It's about making sure that you've got someone who's got a clinical knowledge about this, who's undertaken dedicated training and is disseminating this. You need to be of good or higher rating on CQC, and it's about but I think you can tick all those boxes, including and the sort of key areas are on the next slide, which is about registering your patients, so making sure you're coding your patients properly, registering and coding patients as veterans, having a clinical lead and having the training. But you can have all those things going on, but that doesn't necessarily mean that the veteran walks in and knows that this is a veterans friendly GP practice, especially if they come up to the receptionist and they say, I'm a veteran, and the receptionist is busy and she says, so what? And you can, because the veterans are the way they are for various reasons, they have to make life decisions about is something good quality or bad quality straight away. That's the way they've been trained. They might dismiss you before they've even got to see someone clinical. So it's about having not just a clinical lead, but having a very practice-centered approach on this topic. And I think that's really important. So I'll move on to structure and organisation. I'm not going to test you on whether the structure and organisation of the armed forces, but I'm just really here to say it's really important to veterans because it means life and death. They need to know under pressure, under very harsh circumstances, being under fire, for example, who they're answerable to, what their duty is, what their role is, what their competency is, but who they are, who is answerable to them. And they need to be able to sort of almost pick up and hit the ground running with and work with teams that they've never met before. So all these things like ranks and organisation are very important to them. I used to be very dismissive of it, but this is about efficiency and layers of teams, and life depends on it. But I think what you need to know from this is that as a GP, if you're a GP, for example, in a practice, you're automatically of officer status to that veteran. That can be helpful, but it can also hinder your conversation with the veteran, because they might not want to say things, like they might not want to swear in front of you. I know it sounds, but when you're talking about mental health problems and you're not necessarily got great understanding of language, around mental health, a veteran might want to say something like, I feel effing shite, but they can't, they don't know what they can't find the words for it in any other way. But if you're of officer status to them, they will not want to swear in front of you. So that can impede your relationship. Also, they will equally sometimes listen to you because you are of higher status to them. But it's really important to think about. Just to remember that reservists are, we're getting increasing numbers of reservists. They're more likely to be deployed than they used to be, and they're more likely to return to the care of the NHS and not military health care. Because they're not under military health care once they're back home. And it's important to know that you've got reservists, because you might be assessing them and you might think, oh, they're not fit to drive. I'll tell them to inform the DVLA, but have you told them they're unfit for live arms on the weekend when they go to live arms training? Are they unfit to be deployed? What risks are they going to be to other people within their training or their deployment if they are deployed? We need to think about that. And we are not necessarily, I used to be a military occupational doctor, but we are not military occupational doctors. And that is also something to think about, is that their doctor when they were in the military was also their occupational doctor, whereas now their occupational doctor will be separate from you. So as if so the occupational healthcare is separate from your GP practice, whereas it's one and the same in the military. So that's a very different environment. Just going to culture and values, just to mention it, is that even if they weren't attracted by the military culture and military values, they are ingrained into them. And this selfless commitment, courage, discipline, integrity, and loyalty and respect is great. It's the thing that gets them through a battle. Knowing that the person next to you has the same values and is going to look after you like they look after themselves is really, really important. But also means that when they don't live up to those values, they can feel very ashamed. Shame is a barrier to care. They can feel that they're not worthy of help. They can there's a whole load of negative impact that has on their willingness to talk about what's happened to them, willingness to engage with those services. For example, Help for Heroes is great, but if you feel that you've let the side down, and you're not worthy of help, why would you go to a service that's called Help for Heroes, for example? So it's important to think about that. It's important as well to think about the fact this is why they judge you, because this is all life and death. Life depends on all of this. So if you wouldn't, for example, if you don't have the same standards as them, they will not want to engage with you, as well, because they think, if you can't look after me, if you don't live up to these values, you can't look after me like I'm expecting to be looked after. So we're looking at high culture and values. It's a highly organised environment, as we've said. They pride themselves in professionalism because they have to believe they are the best, and they're very professional. That everyone around them is professional because they're going into very different, dangerous situations. So they need to know that everybody's got the same standards as them, looking after their equipment the same. And they need to be prepared. They're expecting to respond quickly. And so this is why timekeeping is important. Again, it's a life and death thing. As I've mentioned before, we need to think of females in a very macho environment. They might, for example, have been living up to their peers. So they might have been trying to drink the same way as their peers. And obviously women are more affected by alcohol earlier at similar levels. But also might be, expecting to compete on a physicality point of view. So they might have more wear and tear to their joints and their back and things because they've been trying to carry the same weight as their male peers, and they're not necessarily got the same strength as their male peers. They're resilient and stoic and trained to face danger and cope. So they won't tell you they're in pain. They won't take painkillers. They only take painkillers to carry on. They won't take pain. They won't think about treating the problem. They'll either take painkillers to carry on, or they won't want to admit they're in pain. So this means that their engagement with healthcare can be impacted. They are very good at looking after each other, though. So this is great. You know, when they hear good things about a practice, or they hear good things about services, that will be great for you. But if they hear bad things about practice, they will rely on each other's opinion, and that might have a negative impact to your engagement with veterans in the population. Just quickly mention transition. We need to think about why they were discharged. Were they discharged medically? If they were discharged medically now, they get, if that's for a medical problem rather than a psychiatric problem, they will still get psychiatric screening. They can still be missed. And there's reasons why that might be missed. And that includes within the veteran. The veteran might say, well, it was missed. They wouldn't notice I had PTSD, but they may not have wanted to admit it at that time for a variety of reasons. They may be discharged temperamentally unsuitable for the military. That might be because they're a bit like a square peg in a round hole, that the military doesn't suit them and they don't suit the military. That's usually in the first couple of years. Might have been services no longer required, if they've been replaced by reservists, things like that. And they might have been discharged because of failing drug testing, and immediately discharged with no support the next day if they failed a drug test, for example. And so there's a whole range of reasons, and that's really important to know, because that impacts on how their transition might go. If they've been discharged with for something dishonorably, they won't be entitled to resettlement, things like that, in the same way. And if they've been discharged early, they might not be entitled to full resettlement packages as well, which helps them with their progression into the civilian world. We know their support network will have changed dramatically. We know that peer support within the military is protective of mental health, and then suddenly, while they're going through this quite difficult transition, difficult things to transition into a civilian world, they've also losing the usual support networks. They're away from the people that they would normally be supported by, and quite often they go and live with their wife. Classically, this is not being sexist. Women who have had children tend to want to live, it's particularly in the Northeast, seem to want to live near their families. That's the last thing I wanted to do when I had kids. But they wanted to, they quite often want to live near their families, the women do. So the man is not just removed from his peers within the military, but he's removed from his own family. Because for example, because they're quite a mobile population, they might not be from the same area. So he might be away from the people he knows and his normal support network. We know that they struggle with the adjustment to civilian life. Like I said, pace, timeliness, speed of response, all these standards, this sort of high professionalism, all those things that they pride themselves in. They look at us and they see that we're very different in the civilian world. And to them, that's really important. To us, it's not as life and death. And they also struggle sometimes with doing things that were previously arranged for them, like housing, finances, accessing medical services. Their medical support, if they are sick on one day, their medical support, is very much that they have to seek medical support on that same day. If they're either then downgraded or they're sent back to work, and they're ordered then to come to the next appointment. So they're seen on the same day, and then they're ordered back for an appointment. When do we see someone on the same day? When they've not got something particularly serious. We don't order them to come back. We expect them to make another appointment. So it's suddenly very different to the different world and different organisation, and they don't feel that they need to constantly explain themselves in the military healthcare profession, because that follows them around. Their medical officer goes with them. We have, if we move around the country, we get a different doctor, and we quite often get a different doctor every day. So we see someone. So it's very, very different. They might not recognise that they've got skills that can transfer into the civilian world. That might lead to not being able to access, jobs, things like that, which will impact on them. We know that early service leavers are particularly vulnerable to mental health. I'm not going to elaborate on that today, but it is really important. They are actually the more vulnerable group. They're the group that's the higher rate of suicide when we talk about veteran suicides, things like that. And we know that some of them have run away from their previous life to join the military, and then maybe having to go back to quite adverse circumstances. They might spend more time with their families. It might be around triggers for trauma, and they've experienced a lot of losses: loss of job, loss of identity, loss of physicality, loss of peer support. We know in mental health that losses equals depression, and you've got all this happening when they might be being medically discharged as well. So we need to really think about adding the additive impact to someone who might be being discharged from mental health problems already. So somebody who's early service leaver and who has been discharged from the military, has left the military within 2 years, is a high risk, is someone we really need to look at. So being 2 years within transition or early service leavers is the people we really want to be focusing and drilling down to. And we know that they have dysfunctional coping mechanisms, like they're more likely to be express themselves in an aggressive way. Anxiety is expressed as aggression, low mood is expressed as aggression, and this is how they deal with their emotions, or they use alcohol to suppress it. I'll quickly go through barriers to care, and then a bit about resources. So when we're thinking about barriers to care, there's a lot. Firstly, they stigmatize themselves. It's not something they do consciously. It's just that you can't have a duvet day in the middle of a combat zone. You have to crack on. So you have to minimize physical and mental health problems and crack on. And that's really hard to then not minimize them when you're not in the battlefield. So it's very hard to undo and unpick. So they see illness as weakness. They see help seeking, particularly outside of the group, as failure and disloyal. So they're not likely to want to seek help. It's sort of, especially mental health, but the physical health as well. But mental health is seen as your weakness. Sort of is they used to use terms like lack of moral fibre, things like that, and it's still that sort of attitude because it has been protective in the battlefield. So there's been a reason for it, and I think we forget that reason for it. So we need to just be aware of it. They might have poor social and domestic support. They might fear losing control. Loss of control is a real fear of veterans who have got mental health problems or physical health problems, like pain, for example. They might feel guilty or shameful and not worthy of help, particularly survival guilt, moral injury, and therefore they might not feel that they deserve it. And they might have seen people in a lot worse situations than them as well. They're used to protecting others from what they've seen and done, so they might not want to tell you about what they've seen and done because they don't want to put that in your head. So it's about saying, I don't need a lot of information, I just need something to go on. I don't need a full description, I just need an idea, gist of what's going on. That gives them permission to tell you something. Just being aware of the public perception. They're either seen as heroes or zeros in a sense. They're either seen as having PTSD or being in prison or being suicidal, or they're seen as or being involved in unjust wars, or they're seen as heroes, and the middle ground isn't there for them. So the public perception makes them less likely to present for a variety of reasons. If they're feeling shameful and they think veterans are perceived as heroes, then they won't come. But equally, if they think they've been in a war that's perceived as unjust, like the Gulf War, they might not want to tell you what they've done because they might think you might judge them. And they find it difficult to recognise they've got a problem, particularly things like alcohol, because they see that everyone around them used to drink like that, so I don't understand it, and we do know that they've still got higher rates, even in the military now, of drinking, than the civilian counterparts, even though it's improving. They have poor knowledge, as I've said, of access to services, but when they leave, they perceive that we might not understand them. As I've said before, they perceive that colleagues might fail to sort of really, they hear colleagues failing and they listen to their colleagues and they trust their colleagues' opinions, and they hear that. And if they see, even if it's the peer that is not doing well for a variety of reasons within the peer, they will judge the service that the person's been to because of that failure. We know that self-medication for alcohol use and its impact prevents people accessing services, like even within mental health services. I find that difficult getting my veterans who are drinking access because of, even though there are lots of policies now saying it's integrated care, it's still it's in strained systems. It can be very difficult to get the right care for this population. Their perceptions of us, their expectations of us. And I think an example is they judge us straight away. They have to make immediate decisions on is something safe or not safe, because it's life and death. So they look at us, they make a snap decision. She's scruffy, her shoes aren't polished, therefore she's not like polishing a shoe. She's unlikely to be looking after equipment very well. She's not looking after equipment very well. How can she look after me with any standard of care? So that's what's going on in the head. And I've said this to a few veterans, and they've gone, "Oh yeah, that's exactly what I do. I just didn't know I did it." They struggle with things like auto discharge. They struggle with multiple assessments telling the story several times, and particularly if it's a trauma story. They might be being re-traumatized by telling that story over and over again. So it's really important to be aware of that. And they're better if they have a full plan of care and they know what's going to happen and what's like, and that even if they are being passed from pillar to post, why that is, it's really helpful. So just finish with a couple of slides. So what I think is useful to ask is very much what I've talked about today. Is have you ever served in the armed forces? Were you a regular? Were you a reservist? Get the service number, because sometimes 10% might be elaborating the service if they ever, or they might never have served. But get the service number, because it's not just about checking were they a veteran. It's about seeing if we can access information, from them, but we need that consent as well. And and if we've got a service number, it opens doors to a whole variety of free services for veterans, including online services. So if you've got the service number, you can access a lot of services for them quickly. So it does, but explaining that, I need your service number, so it's like a key to a door to all the veteran support that you can get. Find out who they serve with, what did they do, were they deployed, were they in a combat zone, were they a chef, what were they doing, were they doing jobs that were unfamiliar to them? That's sometimes, were they doing jobs that they were familiar to them? Those sort of things, when did they join? When did they leave? That's helpful. Were they, did they attend mental health services? DCMH is the mental health services in the military. Pre-service vulnerabilities, we know that the population that are more vulnerable to trauma in the military are the population that don't do well in healthcare out of the military are the ones that have pre-service vulnerabilities. So do we know that? Have we got that? What support have they tried to get, and why didn't it work if they did? And try and get consent to get the military medical records. And then the final slide I think the final slide I'll use there is just the resources. We've got a whole load of resources. I call it top of the ops, really. So you've got Operation Courage, Operation Restore, Operation Fortitude, and Operation Nova. And even we get them muddled up in when we talk about them. So Operation Courage is the mental health support. It's very much what was the TILS hit high impact service and CTS services. So we've all merged. We've got pathways within Operation Courage to the equivalents of those services now. So we've got sort of crisis services, complex mental health, complex psychological services for military attributable trauma, and then we've got the sort of generic mental health service, mental health engagement services. Operation Restore is what used to be the trauma network, so physical health. Operation Fortitude is relatively new. It's the homeless veterans, and Operation Nova is for those in the criminal justice system. So that's even people on probation, things like that. If you want any other access to other support, I use the one-stop shop, which is the Gateway, the Royal British Legion Gateway. So if you're wanting sort of advice on benefits for veterans in North Tyneside, for example, then you type, North Tyneside benefits, and the appropriate services crop up into this gateway on the Royal British Legion, and there's an app as well. And also they can access Together All, which is an online mental health monitored site. It's not specifically for veterans, but veterans can get it for free as well. It's usually for veterans who are not keen on engaging with mental health services. This is the dipping their toe in the water, for example. So I'll finish there, because I know I've gone over, sorry.